Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with bilateral fully occluding earwax, and in their left ear they also had some really hardened dried keratin, so dead skin, that was embedded in the posterior superior quadrant of the eardrum. So that area of the eardrum in relation to the right ear, we can describe that as being northwest if looking at a compass. Now, the posterior superior quadrant of the eardrum is a very critical and important landmark on the eardrum, because that's where a cholesteatoma can form, and a cholesteatoma can be life-threatening if left untreated and undiagnosed. And you'll see that as the video progresses, you'll see how embedded that keratin was. Now, this patient actually attended a while back, and they had a similar problem then with the keratin. We did refer them to ENT for further examination at the time, and they've just received their appointment. At the moment, the NHS is just under extreme pressures, so it's quite a lengthy wait for this patient. But they have received an appointment. It's still not due for a few weeks, and the patient is really suffering, so they decided to get their ears cleaned prior to attending. I've just installed some olive oil spray just to soften this wax to get a better suction grip. Now, I am actually suctioning whilst the oil is still in situ, so it's still in the ear. When I first started using olive oil spray during my procedures, I used to allow it to penetrate for a few minutes with the patient's ear facing towards the ceiling, so this oil can seep into the ear, soften and penetrate against the hardened wax. And after a few minutes, I would ask the patient to tilt their head in the opposite direction so we can drain the excess oil out of the ear. But more and more now, I'm actually performing the procedure whilst the oil is still in situ. Now, the only difficulty with that, and you can see that it just occurred there, you can get some blurring. So it's only something I recommend if you're quite experienced and you've been doing this for a while. And the reason why the blurring occurs, of course, is when you're suctioning, some of the oil is also being vacuumed, and it's just obscuring the optical axis of the endoscope, and it's causing a light to reflect and refract. However, despite that, the olive oil spray really does help in the ear, because it just allows me to get a suction grip. It lubricates the ear canal walls, so it reduces any friction between the wax and the ear canal as I'm extracting the wax piece. And in addition, it lubricates the inside of the suction probe. Quite often when you perform earwax removal, earwax can get trapped up the suction probe, and you then have to exit the ear and use a cleaning rod to remove the blockage. So you can see the majority of the eardrum now. That was the last large piece that we just removed from the roof of the eardrum. And now you can see the eardrum, but this region here, which I'm now going to use a fine end to try and peel away this skin. Behind this skin, we're just going to be wary of a cholesteatoma formation. And it's a very difficult region of the ear to perform microsuctioning because it's very sensitive. The top part of the eardrum is a lot thinner than the rest of the eardrum. So the top part of the eardrum, we call that the pars flaccida. There is other names like the attic as well. And the eardrum in total has 3 membranes. The outermost membrane facing towards us, the entrance of the ear, that's made up of the same skin that lines the inner 2/3 of the ear canal, the epidermis or epithelial skin cells. The innermost membrane, that's called the mucosa. So the mucosa is a secretory membrane, and although it's not quite exactly the same type of skin cells as the mucosa found in the nose, it still falls within the same family, so it's a secretory type of cell. And then the middle membrane is made up of fibrous tissue, and in the case of the pars tensa, this fibrous tissue is aligned in such a way to give the eardrum a lot of structure and rigidity. But in the pars flaccida, there is fibrous tissue there, but it's a bit more diffuse. It's not aligned optimally. So it just makes the top part of the eardrum a lot thinner. And as a result, if you have negative middle ear pressure, and I'll explain what that is in a moment, the top part of the eardrum, the pars flaccida, is more susceptible of being sucked in because the eardrum is thinner. So behind the eardrum, we have the middle ear, and the middle ear should be air-filled, and the air pressure behind the eardrum should be the same or similar to the air pressure in the ear canal. And when the air pressure is equal, either side of the eardrum, that's when our eardrum is most mobile, and that's when we hear the best. What regulates the air pressure behind the eardrum is a tube called the eustachian tube. Unlike the ear canal, the air pressure in the ear canal, air can simply enter or exit via the ear canal. But behind the eardrum, it has to enter via the eustachian tube, which is a narrow tube that connects the back of the nose, the nasopharynx, to the back of the eardrum in the middle ear. And the eustachian tube is typically shut under normal resting conditions, but during the course of the day, without us even really noticing, when we swallow, yawn or chew, the muscles either side of the eustachian tube contract. That causes the eustachian tube to momentarily open and the air pressure can equalize. If that eustachian tube gets blocked for whatever reason at the back of the nose, and possible causes are you're just born with a narrow eustachian tube, or the muscles have become weakened or paralyzed, or there's a physical obstruction or inflammation or mucus there. The eustachian tube isn't able to function as it should, so we call it eustachian tube dysfunction, and that can create negative pressure because no air can travel up behind the eardrum via the eustachian tube. So that negative air pressure then causes the eardrum to collapse inwards, it buckles inwards, so it creates a vacuum effect, a suction effect. And when the eardrum gets sucked in, especially in this region here, and you can see I just removed, some skin came away. So what can happen here, you can get a retraction pocket, the eardrum gets sucked in, and dead skin that would normally shed and migrate off the eardrum and out of the ear canal, it gets trapped in this pocket, the retraction pocket, and this dead skin can then form into a plug and get infected, and it can grow inwards through the eardrum, to the left in this case, because this is the patient's right ear, to the antrum or antral, to the mastoid bone. So the mastoid bone is the bone directly behind the ear canal. So the ear canal, the bone is called the temporal bone, and to the left of that we have the mastoid bone. It's an air-filled bone with a honeycomb structure. I'll just come back to that. So we've removed as much keratin as possible. The patient will just need to use some drops, some softening agents, drops prior to attending the ENT appointment to have this really examined. We got as much out as we could today, and I did manage to extract some from that pocket. So yeah, the cholesteatoma can start growing inwards towards the antral region, which is the kind of almost the lobby or the entrance to the mastoid bone behind the ear canal. And it can then grow upwards towards the brain, so it potentially can cause meningitis or brain abscess. It can also begin to erode the balance organ. So the balance organ, we call it the semicircular canals. There's 3 semicircle canals which are encased in bone, and the cholesteatoma can, if it's diseased and infected, it can start eroding some of the bone of the horizontal semicircular canal in particular. And it can also, the cholesteatoma can start to cause disease and erosion of the ossicles, the 3 bones, the hammer, anvil and stirrup, also known as the malleus, incus and stapes, and also the facial nerve. So the facial nerve is the 7th cranial nerve that runs in the middle ear, adjacent to the oval window. So the oval window is the gateway to the organ of hearing, the cochlea. So a cholesteatoma is not something that you can just simply ignore. It is potentially life-threatening if undiagnosed, so we don't want to take any chances. And this patient has got a history of eustachian tube dysfunction, which more often than not is a precursor for the build-up of a cholesteatoma, because it causes the eardrum to get sucked in that region, the posterior superior canal, region of the eardrum. So I've managed to remove the majority of the wax from this left ear. Now this left ear is also retracted. You can see that retraction pocket there, but it's clean, it's self-cleansing. There's no keratin. I'm just having another good look. There's no keratin migrating and embedding within the retraction pocket here. I confirm that they have got negative middle ear pressure, so eustachian tube dysfunction. We do that using a test called tympanometry. Well, I hope you enjoyed that video, guys. Do stay tuned. I've got loads more videos to upload in due course. Thank you. Bye.